So welcome to our event today. So costing the impacts of asthma, hay fever and bushfire smoke on the Tasmanian community. So first of all, I'd just like to acknowledge the Muanina people as the traditional owners of the land upon which we're meeting today and pay my respects to their elders past and present. My name is Penny Jones, as you can probably tell from my Zoom name. And I'm a research fellow in the environmental health team here at Menzies. Faye Johnson is the lead of the team, but she's enjoying some very, very well-deserved leave at the moment. So unfortunately, you're stuck with me as the chair instead. So today we've got Nicolas Borchers Arriagada presenting two talks. We'll first have a talk on the cost of asthma and hay fever in Tasmania up until around about 2 o'clock, including time for some questions and discussion. Then we'll have a short break. Those of you who are only interested in that first chunk are free to leave then. Otherwise, we do hope that you can stick around for the second half, which will be analyses of the impacts, health impacts of the Tasmanian 2019 bushfires, as well as the mainland 2019-20 bushfires. And then we'll have some time, hopefully, for an open discussion and Q&A. So just to I think most people are pretty good with Zoom etiquette these days, but please do stay on mute and use the chat box for any questions. And you're free to put any questions, just you don't have to wait till the end. Feel free just to put questions in the chat box as we go along. So just to introduce Nico. So Nico joined us in 2018 and he's doing a PhD with Faye Johnson, Andrew Palmer and others as supervisors on the health and economic impacts of smoke. And he's originally from Chile, where he worked as an environmental and energy consultant. And when he gained quite significant experience through that in performing health impact assessments and using health economic principles to do policy analysis for the public sector. So he brought that incredibly valuable skill set over with him, and he's now applied that to all sorts of projects via his PhD, including the ones he's going to be talking about today. So the first talk today, as I mentioned, will be on the costs of asthma and hay fever in the Tasmanian community. Hay fever actually affects over 1 in 5 Tasmanians. We're second only to the ACT in our rates of hay fever. So certainly a really pervasive disease and one that can often get overlooked. So this is the first health economics analysis that has been done of hay fever in Australia for quite some time. So fantastic to have the opportunity to do that. I just would like to acknowledge that this particular project was funded by a research enhancement program grant from the Menzies Institute for Medical Research. We haven't published this particular study yet, it's still under peer review. So, but if you're interested in, we can please send Emerson Easley, who sent out this calendar invite and email, and we can let you know when that's, that is published. All right, so without further ado, I'll hand over to Nico to talk all about pollen and hay fever in Tasmania.
Okay, again, I was muted. I will present this project, which was about the cost of asthma and allergic rhinitis or hay fever in Tasmania. This was done, we started last year and finished around mid this year. We sent for publication, but as Penny said, it's not published yet. Okay, so first I would like to acknowledge co-authors. So Penny, Andrew Palmer, Bonnie Beresnicki from the School of Medicine, Nick Cooling, School of Medicine, Janet Davis from the Queensland University of Technology, and Faye Johnston. And as Penny said, this was funded by the Research Enhancement Program grant from last year from Menzies. Okay, just a little reference, but it hasn't been published yet, but it will. So this is the main structure, similar to the articles. It would be easier for me to prepare it this way. A little bit of background. So asthma, these are figures from 2015. So worldwide, there are more than 350 million cases of asthma. And it has been estimated that asthma accounts for about a little bit more than 1% of all disability adjusted life years, and also is responsible for more than 390,000 deaths. This is worldwide. When we talk about allergic rhinitis, which is caused by the immune system's response to allergens, this is one of the most common diseases. So it affects up to 25% of children and 40% of adults. And usually asthma and allergic rhinitis come together. And the severity of diseases is worst when the other one is present. When we look at it from a health economics perspective, we can see that these two diseases impose a significant health burden on society, and especially if we talk in monetary terms. And some of the aspects that or the components of this burden include hospital admissions, pharmaceutical expenditure, and lost productivity. So this is just a sketch of the cost types when you're doing an assessment of this type. So mainly you would have three cost types. So direct costs, which relate to the management of the disease and would have aspects such as the cost of emergency department presentations, GP visits, and other things like imaging and pathology. Then you have indirect costs, which include premature mortality and productivity loss at the workplace. So at the workplace or because of being absent from work. And furthermore, you could quantify intangible impacts, such as the loss of quality of life, which we didn't do for this case, but I wanted to put it here. So a little bit of the costs. We looked at different studies, and Nunes et al., they did a lit review on the social costs of asthma, and they found that there was a high variation in cost amongst different countries. So on average in Europe, that would be around 2,500 Australian dollars. This is the cost per person year, so yearly costs. And in the US, a little bit higher, so a little bit over $4,000 Australian. Then Velopoulou did the economic burden of asthma in Greece, and they also, what they found, so you can see the cost disaggregated. So direct costs, they looked at the cost from different perspectives. So you can look at it from the perspective of the patient, of society, of the payer. And they saw that the cost varied between $220 to $1,300 per patient year. But they did find that 90% of these costs were due to direct costs. We saw that these numbers varied a lot, and there is not a consistency in the types of costs that they included for this analysis between different studies. So this could be one of the factors that shows this difference. Furthermore, Carter et al. Looked at the cost of allergic rhinitis, sorry, you should say cost of allergic rhinitis in the top, in Sweden through a questionnaire, $1,500, sorry, per patient year. But they did find that indirect cost accounted for more than 70%. So this would probably be mainly due to lost productivity. Colas et al. Did something similar in Spain, a little under $4,000, but again, over 70% indirect costs, with presenteeism representing 70% of total costs. And Lineberg et al. Did a systematic review on AR and allergic asthma in Europe. And they also found that absenteeism and presenteeism were the highest components in Europe. And you can see the range there, direct costs. They looked at different countries, and some countries had studies only for AR, some for allergic asthma, some for both. So there's a lot of variation, but between 250 Australian to 1,600 Australian for direct costs, and between 850 Australian and up to 10,000 Australian for indirect costs. Now coming back to Australia, Australia has some of the highest rates, or prevalences of these two diseases in the world. From the latest National Health Population Survey, 11.2% of people have asthma and 19.3% have allergic rhinitis. But there is limited evidence with respect to the cost. So we found 2 studies. The first one by Access Economics, 2007, looking at the cost of allergic diseases in Australia. So this wasn't just allergic respiratory disease, but included skin and all allergic diseases. And they estimated total cost of 7.8 billion per year, which is huge. And as you can see, between brackets, also most of it was because of lost productivity. And the latest study by Deloitte Access Economics looked at the hidden cost of asthma. So this is only asthma, not allergic asthma, which is probably a large proportion of asthma patients, and they estimated $3.3 billion per year. And this value would go up to 28 billion if you included burden of disease. So this would be the intangible cost that I explained earlier, quality of life. When we bring this down to Tasmania, so Tasmania has a population of just over 500,000 persons and has the highest rates in Australia. So 13% have asthma and 21% have allergic rhinitis. And if we think about comorbidity of these 2 conditions being comorbid in some cases, you might have maybe around 25% of the population having one or the other or both. We also saw that, or the survey shows that the rates are increasing, at least for AR. And as Penny said, there's really no comprehensive studies looking just at the cost of allergic respiratory diseases, except these 2 studies I showed earlier. And we thought that Tasmania could be an ideal for a case study and maybe develop a framework for a potential national assessment. So the objectives of this study was to quantify the direct and indirect cost of asthma and AR in Tasmania, Australia. And these are the costs that we included. So we used publicly available data to quantify. So this is like a modeling approach to quantify each of these subtypes or outcomes or components of cost. So ED presentations, hospital admissions, medication use, GP visits. Then we grouped these other standard medical services and investigations, imaging, pathology, and specialist services, just because the detail of the information that was available was grouped. And in terms of indirect costs, we looked at premature mortality and 3 components of lost productivity. Some general assumptions. We used 2018 as the year we would model the costs because this was the latest cost where we had more information from these public sources. So that would be Australian Bureau of Statistics or Australian Institute of Health and Welfare. We looked at Tasmania, and because we used publicly available data and all the costs were, not all the costs were for 2018, some were for 2015 or earlier, we standardized this, and so all the costs were adjusted by inflation to 2018 differently. So for healthcare related costs, we use the health group consumer price index, and for mortality, we just use the all groups CPI. Okay, so our population was, according to ABS, 528,201, and the prevalence, you can see the change in prevalence in time. So in asthma, it's pretty stable, around 13%, but in allergic rhinitis, it's increasing. So we have more than 112,000 people affected by AR and 68,000 affected by asthma in Tasmania. So I'll go into each of the components, showing some methods, and then I'll present the results. So the approach that we use, you have the equation on top, is just cases. This is maybe the sub components is complicated, but we estimated the cases by multiplying an incidence rate, so IR, by the population in the case of ED visits and hospital admissions, and by GP encounters in the case of GP visits. And this table shows some of the parameters that we use, it's not all. So for example, in the case of ED visits, we found from the AIHW that during that period, 2016-2017, there was a total of 1,451 cases of this of disease of asthma. in Tasmania. This value is for Tasmania. And we have something similar for hospital. We also have this value for different years. So we took an average, but I'm just showing a subset here. We have the number of cases for asthma, hospital admissions, for AR hospital admissions. And using these cases, we constructed the incidence rate to estimate the cases for 2018. Then in the case for GP visits, we found the actual incidence rates. So 21 cases per 1,000 GP encounters. So our driver in this case was GP encounters and not people. And for AR, it was 6 cases per 1,000 GP encounters, or as it was published by Faridin and Britt, it was 0.6% of all GP encounters were due to allergic rhinitis. And then the Department of Health publishes the amount of GP encounters per year for Tasmania, and we use that as a driver. Then in medication, we use two approaches, one for asthma and one for allergic rhinitis. So in the case of asthma, and the equations are sort of similar. So an incidence rate times the prevalence for asthma. We looked at the PBS items list. So from the AIHW metadata online registry, so Meteor, they have an indicator, that one, that shows the different PBS items that are linked to asthma. And then when we put those together, we downloaded the number of prescriptions from the Department of Human Services Medicare item reports that shows the prescriptions per month and state and item. So just to show you, this is the website that shows that indicator. And if you, if you go down, you have all the different medications that are considered to treat asthma. In this case, we excluded a few, so ipratropium bromide, theophylline. So we excluded 3 of them because they are also prescribed for COPD and have restricted benefit, so only for COPD. So that's why we excluded those. But it's a very comprehensive list. And then the number of prescriptions for asthma, from this website, you just input the item number and by state, and you can get all the data since whenever. In the case of AR, it was a bit different because we didn't have a list of PBS items for AR, and that is mainly because a large proportion of medication is bought over the counter. But Smith et al. Did a study on the expenditure, pharmaceutical expenditure due to AR, and they sampled pharmacies around Australia. In the case of Tasmania, they sampled 25 pharmacies, and their unit of analysis were pharmacy transactions associated with allergic rhinitis. So using these 25 pharmacies and considering that in Tasmania there's 148 pharmacies, we extrapolated this and estimated the amount of pharmacy transactions for a 24-month period between 2013 and 14. And with that, we estimated that incidence rate. And we were able to extrapolate how many pharmacy transactions would be incurred or would be bought during 2018. Then looking at other standard medical services and investigations, we did a simple approach here. We looked at disease expenditure in Australia by the AIHW, and we just took the components that were missing, which were allied health and other services, medical imaging, pathology, and specialist services. So this disease expenditure is Australia-wide. What we did is that we estimated a unitary expenditure cost Australia-wide, and we applied that cost to Tasmania. So this is the website. You can find all the data from the AIHW, the detailed data. And what we did was we filtered for asthma, for example. And here you have the different components. And we just looked at the top 4, allied health services, GP, medical imaging and pathology, and specialist services, sorry. And then in the bottom, you have the prevalences. We use the prevalence to estimate a cost per patient. And we applied that cost per patient in the case of Tasmania. In the case of AR, the disease expenditure doesn't have a sub-item for AR. It has for respiratory diseases or asthma or others. So what we did was that we did use that component for allied health and other services, assuming that the average cost of AR was similar to the average cost of all respiratory diseases. That was the best we could do at this stage. And we used the 2007 Access Economics report that I showed about allergic diseases around Australia to estimate costs for medical imaging, pathology, and specialist services. So that report, here are the average fees that they use. So a pathology, $20, medical imaging, the average was $252, and they use some assumptions. So for example, on 5.6% of GP encounters, pathology tests were ordered, or on 1.5% of GP encounters, imaging tests were ordered. So we use those assumptions to model these components. And the unit costs that we used, for example, for ED visits, hospital admissions, and GP visits were all publicly available from Australia-wide studies. So $700 for an ED visit, over $7,000 for hospitalization, a bit over $50 for a GP visit. And then for the other standard medical services, these are the costs that we obtained using the methods that I showed you. And obviously, as I said earlier, these are for different periods, but we adjusted all these costs to 2018. In the case of medication also, this is just a subset. We looked at data published by the Department of Health that has costing per each of the PBS items. And you can see here on average, salbutamol, $18 per prescription. I don't know, formoterol with budesonide, $64 per prescription. We have this for each of the PBS items in that indicator that I showed you. And in the case of AR, Smith et al. Published the average cost of each of the pharmacy transactions. So they assessed two types of pharmacy transaction, single Rinitis therapy or multiple Rinitis therapy. So in the case of single therapy, it's when they would do a transaction for one therapy type, so intranasal corticosteroids or oral antihistamines, one of them. And in the case of multiple therapy, it was when it was combined usually with another condition. So another medication to treat asthma or COPD. And we have the average cost, around $20 for single, $40 for multiple rhinitis. Okay, now going to indirect costs. In the case of asthma, we looked at this indicator from ABS, so 3303 causes of death in Tasmania for 2017. And they show mortality attributed to asthma, ICD-10 code J45. And they have numbers for each year between 2010 and 2017. So we used an average to estimate sort of an incidence rate, which would be 3.4 cases per 100,000 in the case of females, and about half in the case of males. For allergic rhinitis, we didn't find any deaths in asthma. Sorry, in Tasmania. And to monetize, to value, we use the value of statistical life as recommended by the Office of the Best Practice Regulation, which was $4.2 million in 2014 and adjusted to 2018. And this is, I would say, a surprise, at least for me, doing this study. So most of it was because of lost productivity. We used three components. So absenteeism, which is when people lose working days due to having a condition present at that moment. Then presenteeism, which is being able to work, but working at suboptimal capacity because you are having symptoms or mild symptoms during work hours. And then finally, caregiver absenteeism, which is when you lose working days because you have to care for someone. So an elder or your child that is having symptoms or having an attack or something. And there wasn't much information for Australia. There is a study done by Medibank, private, called Economic Modeling of the Cost of Presenteeism in Australia, 2011 update, and we tried to get it, but it wasn't online, and we contacted Medibank, no, nothing. And when we looked at international studies, there is a lot of information on this. Well, there is a lot of information on presenteeism and absenteeism in Australia, but not specifically for asthma or AR. In the case of international studies, there is a lot of evidence and a very high, sorry, that should be HIGH, high heterogeneity in international estimates. So we just took sort of a practical approach. Given that we didn't know how to bring those values to Australia, we decided to make a low and a high scenario. So you can see here for asthma and AR, you have a low and a high scenario for each of the outcomes. So let's say for absenteeism, on average, the low scenario would be 2.6 days a year lost. This would be per patient or per person with the condition. And as a high scenario, which is an average of a multi-country study, up to 23 days lost per year for absenteeism. And then in similar, same units in the case of presenteeism and caregiver absenteeism, these values weren't always presented as days per year. In some cases, it was presented as, let's say, 6% of the time working, you were affected by symptoms, or 20%, or days per week, or things like that. We just normalized everything to days per year. But the idea is that we defined a low scenario and a high scenario for each case. And to cost this, which would be the last three lines, we used the average salaries. So average salaries for males and females per day. So it would be, this would affect both scenarios. $180 per day for females, $260 for males. And in the case of caregiver absenteeism, we adjusted this by the probability that the potential carer was employed. And this was just done as a simple proportion of people that have the condition, the percentage of people that are employed of the total. But that's why the value is lower. So $130 on average, which would be maybe that half of, or let's say maybe 70% of the people are employed. Okay, now the results. So first, the number of cases and medication use. So this is quite large. You have the different outcomes here, and asthma, AR, and total. So more than 1,400 ED visits for asthma, hospital admissions 625, GP visits more than 55,000, and more than 6,000 for specialist visits. And prescriptions more than 280,000. In the case of AR, the largest component was GP visits, which just tells us that people manage the disease through their general practitioners, and single therapy, 224,000. When we look at the costs by multiplying with the unitary costs, so for asthma, we estimated $23 million per year for asthma and just under $8 million for AR. And you can see that the largest component in both cases was medication use. So around maybe 40% for asthma and 70 to 80% for AR. And then hospitalizations and GP visits were quite high also in the case of asthma. And we estimated the cost per person. So this would be the direct cost, $350 for asthma, $70, which this might be a bit low. And then we go to indirect costs. So first, this is the person days lost per year. So that the numbers are really high, but you can see that the highest ones are due to absenteeism and presenteeism. So they range between, let's say in total, between 220,000 days to more than 1,200,000 days for absenteeism, and similar values for presenteeism. So when we cost this, you will see that these values are quite high. These are the indirect costs in $1 million. So for asthma, the cost range between $100 million and $400 million. In the case of AR, they range between $57 and $250 million. In total, up to 660, so maybe around $400 million. And per person, you can see that the values that we obtained are quite similar to what I showed from the international evidence. So for asthma, between $1,500 and $6,000 per person. This is not per population, but per person with the condition. And in the case of AR, between $500 and $2,300 per person. And what really stands out in this case, you have the same costs here in a table, but what stands out is, irrespective of the scenario that we look at for the productivity loss, low or high, productivity loss is the highest component in all cases, for asthma, in low scenario and in the high scenario. The same, yeah, this is just the unit costs, so dollars per person. Okay, so a little bit of discussion. So what happens with respect to other studies? So we found that the estimates that we got for asthma were quite similar in terms of magnitude to what I showed initially for the international evidence, but we did find that the distribution of the costs were different. In our case, indirect costs were the highest component, as I showed in the previous figures. But Velopoulou et al. Highlight that there is a lot of difference in the way countries and studies assess these costs, and some of the difference which are inherent to each of the countries could relate to the GDP, so the gross domestic product, to how the health systems work, to how much financial resources are available for public health, and also what types of methods are used to collect data. All these explain the differences. In the case of AR, there is high heterogeneity in the magnitude of cost. So our costs were sort of similar in terms of magnitude, but from evidence, you saw we had costs between $2,000 per person up to $10,000 per person. But there is consistency in how much is attributed to lost productivity. So in our case, we found that it was more than 88% of costs were because of absenteeism, presenteeism, or caregiver absenteeism. And in the international evidence, it's something similar. Over 70% of costs were due to indirect costs. So this indirect component, so lost productivity. There is a lot of limitations in the approach that we use. So we use publicly available data, and we did multiple assumptions, and this carries a lot of uncertainties. Some examples. So in the case of direct costs, so for example, for asthma, we just looked at PBS items. We didn't quantify over the counter purchase of medication. We also excluded some drugs. Also, intranasal corticosteroids is the best evidence-based practice, and is the most expensive drug. And in the case of Smith et al., only 50% of transactions were for this component, so probably costs were underestimated. But we did find that more than 50% of direct costs were attributable to medication use. So this would be, if you were going to assess direct costs, it would be a component where you want to focus your energy. In the case of indirect costs, again, high variation in productivity loss estimates. Nevertheless, as I explained earlier, productivity loss was the main component in indirect cost and overall. So we think that even though there is some bias in the assumptions, this would unlikely affect the distribution of the magnitude of the cost distribution. So you can see that the productivity costs being so high, it doesn't change very much how much is attributable to direct cost or indirect costs. Indirect cost is the largest proportion. Some implications for policy and recommendations. Given these high estimated costs, we think that it is very likely that interventions that might be designed to prevent these diseases would be highly cost effective and probably produce substantial cost reductions to society. We think that this approach could probably be used for a national level assessment, which could be focused just on estimating the impacts, as we did, maybe with a little more detail, or could also be used to model the cost effectiveness of different public health interventions. And this could help prioritize scarce resources to obtain optimal outcomes. That's it. Thank you very much. How do we do questions?
Thank you very much, Nico. So we've got a few minutes for questions just on this particular topic before we, at about 2:15, so in about 3 minutes, we'll jump to the cost impacts of bushfire smoke. So if anybody online has a question, please put it in the chat box and I'll read it out. Otherwise, there's also a few people in the room, so feel free to jump in the normal way.
I have a question.
Great.
Is it possible to disaggregate those costs into the costs that that individuals have to pay, the costs to the healthcare system, and the costs to private funded to private insurance? I'm just wondering where I think I can assume where the costs would generally fall. I'm just wondering, is that possible to do that? Would it be useful? It'd be interesting for me, but I'm just wondering, is it possible to do it? And
so there is a question whether from the results we obtain, if this could be disaggregated by payer, if this could be distributed, so patient or health system or the state or, you know, or insurance. The way we modeled it, no, I don't have that detail, but that probably could be modeled usually. So for example, in the case of, I don't know, GP visits, you have a proportion that is out of pocket, and then a proportion that is paid by MBS. You could assign the MBS component to the state and the other, or a part to private insurance and part to the payer, to the patient. But we didn't do it. And I think to do it, it would probably take more work. And I think it depends on what is the objective public, who wants that study and those results.
yeah, I would be interested because I wonder whether there's is there a demographic
Inequity.
Yeah, in terms of who is impacted by.
Probably there is. Probably people that are most affected by condition are most vulnerable in terms of socioeconomic aspects, and they probably carry more costs. So
there may be a better way to find that out. Perhaps. Sorry.
No, it's okay. Okay, so there's a question here in the chat. Is there any data on whether ED hospitalizations were first time or repeat presentations? No, in the data that we used, no, we just used aggregate number of ED visits or hospitalizations per year, and we transformed that to an incidence rate. But you would probably obtain this from health services and yeah, but we didn't do it. But we did find, as I told you earlier, a lot of limitations in all of these components. So we had many of these discussions with the co-authors, but there was a point in which no matter how much effort you would put into detailing each of the costs, lost productivity was always the largest component. So the objective of our study was to look at it from a broad perspective. So we decided to keep it simple and assume that there were assumptions and error in the analysis.
Good question. All right, thank you, Nico, and thanks for those questions. We will, got one more question there from Julie in the chat box, but I'm just conscious we might have people joining us for the smoke presentation, so we'll jump to the smoke one, but that, Julie, your question will stay in the chat box and we'll address it at the end. But if it's okay, Nico, I'll ask you to jump to the presentation on the impacts of bushfire smoke. That's right. No rest for the wicked.
Okay, let's see.
that's looking good. Thanks, Nico.
Good afternoon. Okay, so some of you have seen some of these things. This is part of the results of my PhD. So I will show some estimates for bushfires, the cost of bushfire smoke in Tasmania in time, last 10 years. And I will look at the last fire season in mainland that affected all of Australia, mainly the East Coast. And we will look into the past 20 fire seasons too. So an acknowledgement first to my supervisory team, Faye Johnston, Andrew Palmer, and David Bowman. Co-authors, I've had the luck to link with very good researchers in this area, Grant Williamson from UTAS, Jeffrey Morgan from University of Sydney, and Bin Jalaluddin from University of New South Wales. Funding organizations, obviously I couldn't be here without them, and collaborating organizations. This presentation is focused mainly on these two articles. The last one, so this was published in the beginning of the year, Biomass Smoke in Tasmania. This one is a health cost of bushfire related air pollution for the past fire season. This hasn't been published, but I'll let you know, this will be published tomorrow. So maybe we can send through or just have a look at nature sustainability. If you want to have a look, please don't share any of these results until tomorrow. Same structure. A little bit of background. I'll go back and forth between Tasmania and mainland, so I hope you don't get dizzy with this. So I'm focusing mainly on the fires that we had in Tasmania in January last year, okay, or summer last year. So Tasmania, we have hot and dry summers, we have a large foreign landscape, and what does this mean? That we have sporadic bushfires that don't affect every year, but some years do, and they can be pretty bad. Last year, fire burned for around 100 days, and around 210,000 hectares were burned in the state. The most affected part, at least in terms of fire and smoke, was the southwest of the island. And there are multiple impacts. Some of them, we had some houses destroyed and historic structures were affected and different things. But what about smoke, which is the topic of my PhD? In the case of mainland, so the last fires were quite unprecedented. Well, I don't know if you have seen the news, what's happening now in California is what we were living here not in Tasmania, but in the mainland since December, probably last year or November. So more than 8 million hectares of temperate forest were burned. So this was more than the Black Friday fires, which was the largest fires in temperate forest since European settlement. Around 3 billion animals were killed or displaced. And when we think about climate change, we know that natural disasters and this type of fires, mega fires, will be more intense, and we will have longer fire seasons. Also, some other impacts: more than 50,000 fires, more than 3,000 houses lost, 33 lives lost. I saw in an article it was 34. Not sure about that. But what happens with air pollution and smoke? Again, this is a satellite image from the fires last year in Tasmania, and you can see how the smoke is covering most of the East Coast, all of the Southeast. And if you recall, this smoke affected New Zealand too. When we look at the fires, this last fire season, on the top you have two images of Sydney, different dates, 11 of December 2019, 21 of November 2019, and you can barely see anything. When usually summer is the good months, the months where we have good air quality around Australia. And in the bottom, you have a satellite image of aerosols that it's not exactly interpretable, but what it shows is that the smoke from the fires circumnavigated the globe and were seen to go around the world, and were seen again in Western Australia, which is that circle on the right, the same smoke. When we think about impacts from smoke, the main pollutant is PM 2.5 or fine particulate matter. This is particles that have a diameter of less than 2.5 microns. And you can see a typical depiction of the size of the particles compared with the hair. And what happens with this size, evidence shows that below this diameter, these particles are able to enter first the respiratory system and then the bloodstream, and then produce systemic inflammation, and then that produces different health outcomes. And when we think about public health impacts from air pollution, this is a pyramid, sort of like an iceberg. You have in the bottom subclinical effects. So when a large population is affected, we all get symptoms. I got an itchy throat, itchy eyes, headaches during the fires in Tasmania. I think that would be the least. And then as more people are affected and for more time, you have the top. You have deaths, hospitalizations, and other ED visits and other things. And the first three are the easiest to measure and quantify in terms of public health impacts. And it's similar to what I showed in the previous presentation. So they're easily quantified and monetized. So I applied a method called health impact assessment, which I will summarize in this slide. So you have the equations on the left. Firstly, you estimate the cases using a change in air quality, in this case, PM 2.5, estimating exposed population, and then combining with the base incidence rate for an outcome that we want to study. So for example, deaths, the base incidence rate would be the average number of deaths per 100,000 persons. And then health risk coefficient, which is an association between an increase in air pollution and a change in the outcome, in this case, deaths. And once you are able to quantify the cases, you estimate the costs just by multiplying with unit cost. So we start out with modeling the change in PM 2.5. On the figure on the left, we have the observations at a station level, and we used a simple method, like it's a spatial interpolation method called inverse distance weighting to obtain the figure on the right, which gives an exposure at an SA2 level. So this is a standard statistical level 2, which is an administrative geographic level that contains a population, average population of around 10,000 people, each of them. Then we know how much people were potentially exposed because we know how many persons live in each of these SA2s. We also have the baseline incidence rate. Sometimes we have detail on the baseline incidence rate by SA2. Sometimes we just have statewide or sometimes Australia-wide. We combine them with the betas and we obtain the cases. And finally, we multiply by the unitary cost and estimate the cost. It looks pretty straightforward. The most difficult part is really obtaining all the data and the amount of data that is used. So this analysis is done daily. We did the analysis for all SA2s around Australia, all states except Northern Territory, and then we looked at the previous 20 years. Okay, so this type of assessments, they have been used extensively for air pollution, but they haven't been used extensively in the case of landscape fire smoke. So there is just some limited studies. So Faye Johnston and her group, this is my supervisor, did a global estimate, and they estimated that more than 330,000 deaths globally are attributable to smoke from landscape fires. Then I was able to collaborate with her when I first met her after a huge fire that we had in Chile that affected more than 50% of the population for 16 days. And just some of the numbers. So we estimated that more than 70 people died and 200 people went to hospital because of 16 days of exposure. This was also during summer, which usually has good air pollution. Then there's a few studies that have been done in Australia. So Richard Broom from New South Wales et al., they did an analysis of the impacts of hazard reduction burning in Sydney. There was an episode in May 2016. And every now and then we see these types of episodes on the news. So when I just arrived to Australia, 2018, there was an episode in June or July, and last year there was, probably there'll be again. And then a similar group with Josh Horsley looked at the impacts of smoke for a period, so 13 years in Sydney Greater Capital City Statistical Area. So here they quantify that around 200 people died in this period. So more than 10, let's say 15 deaths per year, and maybe 100 hospital admissions per year on average. And then throughout my PhD, I have published a few. One of them looked at the air pollution due to exceedances of the national air quality standards in Western Australia. And we looked at a period of 15 years, and we estimated a large burden, so quantified at around $190 million for that period. It's only exceedances, but we did quantify that more than 50% were due to prescribed burns. This is obviously not exhaustive because it only includes exceedances. And then in February, I don't know if someone saw this, but we did a quick assessment of the burden of the smoke up until that moment. And we estimated, this has been around the news, more than 400 deaths, more than 3,000 hospital admissions, and more than 1,300 asthma ED visits across 4 states, these were the states that were mainly affected by the bushfires. And in the US, this analysis was done by Neil Fan and his team for a period of 5 years. And these numbers are just disproportionate, but because the US has a population of over 300 million people. So obviously around 2,000 deaths per year, and the costs, I don't know, $15 billion per year. But I will show at the end that we're not so far when we normalize these costs. And also this analysis has been done in Canada. This was published recently. Also looking at a period of around 6 years, 5 years. And the costs are a bit lower, deaths are a bit lower. Obviously the population is lower. And okay, so now let's focus on Tasmania. So we're looking at fine particulate matter. This is population weighted particulate matter. So we looked at the state and we averaged by population density. And this is what happens for this fire season. So we defined a fire season, the 6 months between October and March. So this would be between October 2018 and March 2019. In yellow, you have the historical population weighted average. And in red, you have the national air quality standard, the daily air quality standard of 25 micrograms per meter cube. And you can see that the values during summer are pretty low. Tasmania has really good air quality during summer. But then we had this spike during a period of about 2 weeks that was way above the historical, and during some days above the national air quality standards. So during this period, the national air quality standard was exceeded on 4% of days when the historical exceedance was below 1% of days. And the historical population weighted was exceeded on 17% of days, and the historic exceedance was 5.1%. And when we look at a larger time scope, on the top you have historic PM2.5, hourly PM2.5, and in the bottom you have temperature trends. And we have a very distinctive trend. So when it's hot, usually the air pollution is low. When it's cold, the air pollution is higher. This is due to biomass smoke. But you can see in these valleys, there are some spikes in 2013, 2016, and then this was last year. And that is when bushfires are happening during summertime. So, and you can see what I told you, that during summer, usually the air quality is very good. I think it's one of the best air qualities in Australia and in the world probably. When we look at the same figure around Australia, but for the 2019-20 fire season, we can see that the smoke started to be visible late October, so early November. And it just started increasing, and then it spiked around mid-January. And then I think right after January, so just first days of February, it went back to normal. And you can see here also that the summer values are more in line with the long-term historical average. So it's higher than Tasmania, but there's still good air quality during summer, usually. Again, during this time, this looks at all states except Northern Territory. So the national air quality standard was exceeded, the population weighted average exceeded that on 11% of days, when usually the historic was 0.1%. And the historical population weighted PM2.5 was exceeded on more than 60% of days. You can see all these points above the yellow line. And usually the exceedance was around 50%. So, yeah. Okay. Then, so we estimated the population weighted PM2.5. Each line is a state, and the dotted black line is all states combined. This is since the 2000-2001 fire season. And there seems to be like a sort of similar trend. And then this season, you can see how it spiked. In red, ACT. So there was really bad air pollution for some days in ACT, up to 1,000 micrograms per meter cube. But we also see here some spikes in New South Wales, green Victoria, and this one, I think it's Queensland. Yeah. And then you can also see Tasmania, which is the purple one. You can see the spikes I showed you earlier in 2016, this one, and then the spike here in 2019, which was the bushfires last year. So the objectives of this study were to estimate the health impacts and costs. Well, first up, I will show the 2018-19 fire season in Tasmania, then the 2019-20 fire season, all of Australia, and then just show some comparisons with previous fire seasons. So in Tasmania, in red, you have the location of the fires last year. And mostly, one of the most affected areas was the southeast, and here around the Huon Valley, no? Jedburgh, Huonville, Giveston, Cygnet. And if you can recall, we had a few really bad days in Hobart too, depending on where the wind was blowing. In the case of the Australia-wide, we analyzed all states except the Northern Territory, because during this fire season time is wet season in the Northern Territory, so there are no bushfires, or it's pretty negligible. So you can see the fires, panel A, population density in panel B, the location of monitors in panel C, so around the coast, which coincide with population density. And yes, and in black, you can see the SA2, so the standard statistical level areas 2 that we used to assess. And when we look at the affected stations in the Huon Valley, this is the daily average. The red dotted line shows the threshold for the daily air quality standard, and highlighted in red are the days when the standard was exceeded. So you can see that during January and February, there were quite a few days, at least 10 days on each station, where the air quality, the standard was exceeded. The standard is 25 micrograms per meter cube, but the average summer values is around 3 to 4 micrograms. So some days the air quality standard was exceeded, but I would say most days the historical values were exceeded. In the case of the Australia-wide analysis, what we did was we identified landscape fire days whenever the daily PM2.5 was above a threshold that was defined as the 95th percentile of historical values. And this is a threshold that has been used in previous studies and validated. and then we estimated the portion of smoke attributed to landscape fires as the difference between the observation during a day and the expected value, which we assumed was the historic average. And I would say that this is probably an underestimation, because that historic average doesn't exclude fire days. So the average incorporates the effect of days with higher pollution. So it's probable that the fraction is higher than what we estimated. We used, again, here publicly available data to characterize population. So for example, for the Australia-wide analysis, around 22 million people were exposed, and this was a little under 90% of the Australian population. And the incidence rates varied between states. So we had different ranges between 390, 770 deaths per 100,000 persons, and the same for each of the outcomes. And all of them obtained from ABS, AHW, and in the case of New South Wales, they have really good detailed data on health outcomes: asthma, ED visits, hospital admissions, deaths, by age, by sex. It's really good. The risk coefficients that we used, so for all of these coefficients this is an increase. So this means that, for example, all-cause mortality would increase by 1.2% if we observed an increase of 10 micrograms per meter cubed in one day. So the daily death rate would increase. So these are all short-term exposure risk coefficients. So here there is another underestimation, in my opinion. These coefficients were estimated for sporadic events. So what happens if during one day there is an increase in air pollution? What happens to the health outcomes? But we are seeing, in the case of landscape fire smoke, that fire seasons are no longer fire seasons. They're not longer sporadic, but they are seasons, and people are being affected for months, at least weeks, and this is starting to happen every year. So I think that acute exposure will start to become chronic exposure, and the health impacts are going to be magnified by this. And then in the fourth column, you can see the costing values that we used, which were similar to what I showed in the previous presentation. Again, all costs were adjusted by Consumer Price Index. The value statistical life is obtained from a method called willingness to pay, which estimates how much people would pay for slight reductions in risk mortality. And then the healthcare use is a cost of illness method, which quantifies the exact cost of having one admission or one asthma visits, how much it costs the system. So now to the impacts. So in Tasmania, this fire season, we have, this might be low impact. So we estimate around 5 deaths, 30 hospital admissions, and 11 asthma ED visits. And we quantified $22 million. So this might be low, but when we this has to do with Tasmania having a low population. When we normalize this to a population of 100,000 and compare with estimates from other countries, you will see that it's quite considerable. In the case of the past fire season, so these are results that will be published tomorrow. So more than 400 deaths, 3,000 hospital admissions, 1,500 asthma ED visits, and most important here, almost $2 billion for the past fire season, which is tremendous. And really, this could be any indicator. It could be increased health risk, mortality risk, life reduction in life expectancy or something. So we compared this metric to the previous 20 seasons. This is just Tasmania. So in red, the figure was designed like that, but it has, in red was the last fire season. But you can see that, and day 1 is the 1st of October, and day 183 or 184 would be 31st of March. So this is the cumulative cost per fire season. One line is one fire season. And you can see here in the top, we have 2019 and 2016, which were the years that I showed you that there were spikes in air pollution during summer. And you can see that the average cost during those years is around $24 million, which is quite high compared to the other years. Then when we look at the Australia-wide and the past fire season, this is really unbelievable. In red, these are the costs that we estimated for this fire season, to about $2 billion. And then down here is each of the previous fire seasons for the past 20 years. And you can see that the second after the last previous season was around $500 million, 2003. And we estimated that this around $2,000 million is more than 9 times the median of the previous 19 seasons. So however you look at it, if it's money or some other metric, this fire season was really unprecedented. This figure shows, so I normalized the costs per 100,000 persons just so that the figures that I showed were not biased by the population that was exposed. So we have each of the states here, and I added the US and Canada from the studies I showed earlier. 1 dot is 1 year. In the case of Australian states, 1 dot is 1 fire season. And here on the y-axis, we have the health costs in Australian dollars per 100,000 persons. And you can see that for Queensland, New South Wales, Australian, ACT, and Victoria, in red, which was the last fire season, it was quite high. It was higher than any of the previous fire seasons. And this wasn't the same for South Australia, Tasmania, and Western Australia. But you can also see that in all states and the US and Canada, the range of costs is pretty similar. So let's say between $1 million and $8 million per 100,000 persons, except for what happens in New South Wales and the ACT this year, which was again unprecedented. It's the new word, unprecedented COVID, unprecedented. And then when we look at this same figure, but now on the x-axis, we have the fire seasons. And then each of the points and colors is one fire season per state. We can see how, for example, New South Wales has the highest costs. These are normalized costs, so it doesn't take account population. Sorry, exposed population. So New South Wales, 2002, 2003, Victoria, 2006, then Tasmania. This is the results I showed from Tasmania in 2000. This would be probably January 2016, January 2019. And then this last season, it just went crazy for Victoria, New South Wales, ACT, and this is probably Queensland. Okay, again, this type of modeling has a lot of limitations. Some of the limitations have to do, and we have a lot of discussion around this, has to do with how we value mortality. So some studies have shown that with acute exposure, people that die similar to COVID are people that already have pre-existing conditions or are more frail and elderly. So some people would say that in this case, it wouldn't be methodologically sound to use a constant value of statistical life, because the values that we used don't account for differences by health status or by age. Also, there could be some bias in the way we did exposure modeling. So I told you that we used monitoring data, and then we did a spatial extrapolation, interpolation called inverse distance weighting. I used a simple inverse distance weighting, and there are many more. You can use the more complex one. There's another one called kriging. You can use satellite data. You can do chemical models. And lately, people have been using hybrid. So you do interpolation, you use a model, and then you make the model learn. Okay. But we did use the same method across all regions and years. So probably we believe that it is unlikely that the relative weight of estimates will be affected. So the aim of that study was to show how unprecedented the impacts were during the past fire season. Also, we did not include the full range of possible health impacts. We just included a few deaths, hospital admissions, asthma ID visits, and evidence has been showing that there are more, for example, mental health. And the study that I showed you earlier showed that the largest proportion for asthma and AR, which are respiratory conditions, is the impact on reduced productivity. And we likely had that. People were living in Sydney, couldn't go to work, had to work from home for weeks, were exposed for weeks. Also here, people in the southeast, in the Huon Valley. Also, we see that in Tasmania, although the costs, normalized costs are high, but we see that the cost can be quite high during bad fire years, like such as 2016 and 19. Well, for Australia, again, the impacts have not been seen before. And we're also underestimating impacts because we're only considering Australia. But as I showed you, the smoke from these seasons traveled across the globe, affected South America, affected Africa, came back to Australia. The Tasmania smoke affected New Zealand. And you can see now from the California fires, they crossed the US and the smoke has been seen in Europe. And we think that the magnitude of the potential health impacts that we have estimated due to landscape fire smoke should be enough to push for improved intervention to attack climate change, whether it's mitigation or adaptation, and also to push for a more sustainable fire management. Any questions?
Thank you, Nico. Fantastic. So there's a couple of questions already in the chat box, which we can come to, and that should give people a minute to think about other questions. So we had one question from Jess from Asthma Australia. And this I think might have been, just correct me if I'm wrong, referring back to some of the health impact assessments Nico was talking about towards the beginning, whether they were wildfires, planned burns, or both.
Except for the Western Australia one, which was part of my PhD. All the rest are mainly due to wildfires, not planned burns. In some cases, maybe if they accounted for smoke across the year, you could have planned burns in them, but it's mostly wildfires. I am doing an analysis on New South Wales, trying to decompose what's attributable to landscape fires and wildfires and planned burns, but that chapter will be for the end of this year, next year, but it's coming.
Sure. And we also had a question earlier on from Julie in regards to the pollen study, about commenting on other jurisdictions further in terms of the direct versus indirect split of costs. Could it be suggested that methods are more likely more? Yes, so basically is the difference that we found between Australia, or Tasmanian study finding that the costs were vastly indirect versus some of those European studies finding more direct costs.
What Velopoulou et al. Said that every study is designed differently, and it comes down to how it's designed and the availability of data and the cost components that are included. So not all studies included the same components as we did. Not all included lost productivity. Some only included presenteeism, some only absenteeism. So that explains a lot of the differences. But even with that, we did see that at least for hay fever, no matter the magnitude, the costs were largely distributed to lost productivity. So attributed to lost productivity.
Okay, thank you. I've actually got a question. So please feel free to jump in with more questions in the chat box on any of the topics. I just wanted to sort of jump off sort of from that topic, given that, in the presentation about allergies and asthma earlier, the lost productivity was such a massive contribution to the costs. But then in the smoke analysis, that wasn't included. Do you have a sense of what sort of order of magnitude that would be? Again, would you expect that those would be much higher than the ones we costed?
Yes, I have had included this in reports I've done in Chile. And what we see is that the magnitude of lost productivity is quite high when you look at morbidity effects. So compared to hospital admissions and asthma IV visits, it's high, and it's probably higher than those components. But the way that mortality is valued, usually in these types of assessments, more than 88 or 90% of costs are attributed to mortality. And also, lost productivity isn't included much in these studies because the values, so the association between air pollution and lost productivity, the original association, the latest one, is from 1984, from Bart Osto. And that's the value that has been used in all studies. They all refer to that 1984 seminal study. So, yeah.
Yeah.
But I think it's, given the evidence of the modeling, not the evidence, but the modeling that we did for asthma and hay fever, I think that it would be interesting to look into lost productivity. And also from what we saw from the bushfires, in the last bushfires, and how people in the Huon Valley or in Sydney were affected by smoke, I would say that it carries a pretty large burden.
Yeah, absolutely. Thank you. Is there any more questions? No? All right. Oh, no, I was about to let you off the hook, Nico, but we've got one from Simon. Thanks, Simon, from Canberra. Can you explain a little more why ACT is so high cost? Is there a city bias?
No. So well, if you look at ACT, just let me go back. The cost is high mainly when we normalize the here in that figure. When we normalize the cost, what happened in ACT is that there were a few days in, I don't remember, but it was in January, where it was the worst air pollution in the world, where it was something like 1,000 or above 1,000 micrograms of PM2.5 per day. So that has, so probably a lot of cases. We did twice, and so given that we had this really high air pollution in that day, for the paper that will be published tomorrow, we capped the max daily PM contact to 150. So the results that you have here are for a maximum daily of 150, and then we did a sensitivity analysis on no limit or 300 or 50. But yeah, for ACT it was mainly because there were some days with really, really bad air pollution. Yes. No, we are not getting the cross-border flows into the ACT. So, well, yes and no. The thing is that we are looking at the air pollution at a monitor level. So we're not looking at the fires, really. We're looking at the observations at stations. So if the station is capturing a spike in air pollution, whether it comes from New South Wales or whether it comes from ACT, we count that as a bushfire affected day if it was above the 95th percentile. So I say that, yeah, we probably are capturing cross-border flows. Sorry, Amanda.
No, good question. Good question. Yes, poor old ACT did certainly cop. I think, a lot of places in January got a lot of smoke, but ACT, I think, certainly
was
got
affected with the fires in New South Wales, and then New South Wales was affected from fires from Victoria. But because we're looking at the monitors, we don't care where the fire comes from.
Yeah. All right. Last chance for any questions?
If you analyze Melbourne, would it likely be high? So we did look at Melbourne. It's high, but not as high. You can see from here. The worst affected was in terms of normalized. So per 100,000 persons were New South Wales and Australian Capital Territory. In Melbourne, it was high a few days, mainly during the end of the season. So you could see how the fire was shifting and the smoke likewise was shifting to the south. So I would say that Victoria was affected more towards the end of, or maybe towards January, end of January, early February. Are you also having lots of people from New South Wales coming in which increases costs per ACT resident? No, because we're not looking at actual hospital admissions. We are modeling from epidemiological evidence what would likely happen with the increase in air pollution. So we're taking average yearly incidence rates and we're applying a function to that. Yes, so there's a few CAR that I showed earlier. So the Center for Air Pollution Research and Energy Transitions in that. And there's a few researchers that I think are looking into what are the real impacts, but to estimate the real impacts, we have to obtain the real hospital and mortality registration data. And at that stage in February and what we submitted in March, we didn't have that. It was just a modeling exercise. But it would be interesting to contrast and compare with the real impacts.
Absolutely. All right. Well, thank you very much, everyone. And thank you, Nico, for talking for, yes, nearly an hour and a half straight. So thank you very much. Do appreciate all of the, incredible modelling what you've done. And we'll look forward very much to seeing the paper out in Nature Sustainability tomorrow.
Yes.
So,
and if you're interested on this, you can have a look tomorrow at Nature Sustainability. It should be out.
That's right. And we'll also try and post things on our Aerator Facebook page as well.
Okay,
yeah,
cool. And if you have any doubts or queries or something, you can email me.
Excellent. All right. Thank you very much, everyone, for joining. Appreciate it. And do get in touch with any questions. All right. Thanks, everyone. Take care.
Bye.